Without further ado, because I know we've got a lot to get through, I'm very pleased to have Cheah come and speak with us today. Cheah is someone I've had the pleasure of working with in the past over at Peter Mac Days. So he resides here in Perth now. He works, he's a haematologist and clinical researcher at Sir Charles Gairdner, Hollywood Private Hospital, and Pathwest Laboratory Medicine WA and the University of WA too. And he's also the clinical lead for the lymphoma at Sir Charles Gairdner, and that service is growing from strength to strength, and there's a few Sir Charles Gairdner nurses here. And he's also the director of the WA Lymphoma Centre of Research and Excellence, and really pioneering the area of research in WA and bringing some great clinical trials for lymphoma patients, which is fantastic. And he's very impassioned to improve the access for WA patients to novel lymphoma treatments, where he has been successful to bring many trials to WA, as just mentioned. So please warmly welcome Associate Professor Cheah.
Thank you very much for the invitation to be here, Donna and Sharon. It's been, we've...
Sorry, I didn't put your presentation up.
That's all right, I'll figure it out. Yep.
That's all right. Okay. We'll probably leave these in there.
So Lymphoma Australia has been a great supporter of West Australian patients, and it's always a pleasure to be able to give something back. Right, so my brief is to talk about some of the novel agents which are emerging for patients with lymphoma. I've tried to focus a bit more on those agents which I think are closer to becoming broadly available in clinical practice, or those which look more interesting in early development. I'm not going to spend a whole lot of time talking about CAR T cells, because there are more qualified people who can do that, and you'll hear lots about that in the rest of the meeting anyway. So really I'm going to be talking about sort of more broadly applicable lymphoma therapeutics. So here are my disclosures. I'll focus on these three subtypes of lymphoma, which are some of the, two of the more common and one of the more interesting subtypes of lymphoma. And as I mentioned, I'll be focusing on those agents where there's data which will probably lead to registration soon within Australia and will be widely used in our patients. Starting with follicular lymphoma, the most common indolent lymphoma. Just a bit of an overview about the current approach to management in 2019. I think things have changed slightly in the last 12 months due to the availability of obinutuzumab. So you know that patients with stage 3 and stage 4 follicular lymphoma, if they have no indications for therapy, do not require treatment, and we still watch and wait, and that's still the case in 2019. So patients who have symptomatic disease as defined by the Guelph criteria, and these are largely based around the presence of symptoms or high tumour burden, currently undergo therapy with chemoimmunotherapy. For a long time, the standard of care was antibody-based therapy with rituximab, followed by the chemotherapy regimen, which was either CHOP or CVP. And as you know, for the last few years, we've had access to bendamustine, and that's been widely used now. So the novel anti-CD20 monoclonal antibody obinutuzumab is now approved for the use of patients with follicular lymphoma in Australia. You know that it's basically been modified so that it's more potent compared with rituximab. It's been defucosylated, so it has a greater potency in terms of its effectiveness against lymphoma cells, because the ADCC, or antibody-dependent cell-mediated cytotoxicity, has been optimized. And this has been demonstrated in a large clinical trial, which you will all probably be aware of, the randomized gallium study, in which approximately 1,200 patients with previously untreated follicular or marginal zone lymphoma were randomized to chemoimmunotherapy using either rituximab or obinutuzumab as the antibody of choice. Each site could choose which chemotherapy arm what they wanted to use, so that was non-randomized. And the bottom line is this: at a median follow-up of, this was, I think, 40 months for this updated analysis. The light purple line, or the patients who were randomised to receive obinutuzumab, had superior progression-free survival, and the hazard ratio here was about 0.68, which equates to a 32% reduction in the risk of lymphoma progression or death. Now, there was obviously no difference in overall survival in this study. This is a follicular lymphoma study, and as we like to tell our patients, in 2019, if you're diagnosed with follicular lymphoma, your median overall survival is likely to be 20 years or longer, and that's particularly the case if you don't have what's called a POD24 event, if your lymphoma stays away for the first 2 years after diagnosis and treatment. And the life expectancy for these patients is likely to be considerable. So this study, with a median follow-up of only a touch over 3 years, you would not be expecting to see an overall survival benefit. But it's clear that that obinutuzumab is a more active antibody. Here's some of the safety data in terms of whether there was any difference between the two arms. And really, there was a very slight increase in infusion reactions, a slight increase in low platelets, and a slight increase in infections. But taken as a whole, I don't think that the safety was substantially different between the two arms. And a lot of the discussion around this study was more actually around the safety signal in the chemotherapy arms, remembering that this portion was non-randomized. I spoke about POD24 earlier, and if you haven't heard of this concept, it refers to progression of disease within 24 months of diagnosis. This curve depicts the cumulative incidence of POD24 events in the obinutuzumab and the rituximab treated patients. And while some people contest whether the improvement in progression-free survival for obinutuzumab is actually clinically relevant, given the long natural history of follicular lymphoma, I think most commentators were impressed with the reduction in POD24 events seen in this study in patients who received obinutuzumab. And the reason for that is we know from large data sets like the LymphoCare study, if you have a POD24 event, then you're much more likely to die from your follicular lymphoma. The hazard ratio for death is about, it's about 15 or 20 depending on the study you read. So most of the deaths that occur in patients with follicular lymphoma are occurring in patients who have early progression. And the thought is, if you can use a more potent antibody and prevent these POD24 events, then that's better than treating them once they do occur. How about the chemotherapy regimen? Now remember, this was non-randomized, but this slide shows you that the effect of obinutuzumab as a more potent antibody was fairly consistent across the different chemotherapy backbones. There was no difference between the different chemotherapy regimens used, but remember, this was a non-randomized comparison, so the study was not designed to answer this question. But you can see that there was a fairly consistent trend towards superior performance of obinutuzumab regardless of the antibody used. So in terms of the options that we have in 2019 for treating patients with follicular lymphoma who are in need of therapy, clearly you have a choice of 3 different chemotherapy regimens, and you also have a choice of 2 different antibodies. The choice of chemotherapy regimen is probably the one which requires more thought. I mean, my personal practice has been to almost entirely switch over to use obinutuzumab, given that it's approved and it's more potent and the efficacy is superior. I see no reason to use rituximab anymore, given that the study has been done. In terms of the choice of chemotherapy regimen, you know that we will tailor this according to the individual patient, how old they are, what comorbidities they have, what their various, there'll be certain patients where you'd want to avoid neuropathy, patients where you can't use high-dose steroids because of diabetes, things like that. So really, you tailor things like that. There are also concerns about the increased risk of infection and infectious death with bendamustine treated patients on this study. it doesn't seem to have played out in a lot of the other randomised studies using bendamustine, so there's some uncertainty about how to interpret that. Most of the patients who died on the bendamustine-treated arms were greater than 70 years of age, so I'm certainly very comfortable using bendamustine in anyone under 70, and in selected fit patients over 70 would be worth considering as well. I mean, I think because we haven't seen these results replicated in many other randomised studies, it needs to be taken with a grain of salt. And you guys know, being the ones who are delivering and seeing patients who are treated with bendamustine, that most of them actually look and feel pretty good compared to those patients who are getting chopped. So there was a lot of noise about that at the time this study came out, but I think that seems to have died down a bit. And if you look at, I'd be interested in some of the real world data on this topic, and I know that the Australian Lymphoma Alliance are actually looking at this, and I think we'll see some more data about this in the coming year or two in the Australian setting. So here is just some thoughts I have about when I might like to preference one chemotherapy regimen over another. If patients have major issues with peripheral neuropathy, then clearly CHOP and CVP, which both contain vincristine, are best to avoid. If there's any suggestion that there may be histologic transformation present, I always try to obtain a biopsy to prove this wherever possible, because it has such a large impact on the prognosis and treatment of the patient. But sometimes you may not be able to prove it, and if that's the case, you should definitely use an anthracycline-containing chemotherapy regimen. I have occasionally used GCVP. There are 1 or 2 patients who have been really, they've been worried, maybe they're late 70s, they're a bit frail. You don't want to give them bendamustine because of that increased risk of top events. You may not want to give them anthracyclines. And remember, if you go back to the old studies comparing CHOP and CVP, there was an advantage to CHOP, but that was just progression-free survival. So none of the randomised studies which have compared chemotherapy regimens in follicular lymphoma have actually demonstrated a benefit in overall survival. So bendamustine was non-inferior and had better curves than CHOP in the NHL-1 STEEL study, and similar in the Follow 5 study, the Italian study, but none of these have shown a benefit in terms of overall survival. So I don't think you need to be dogmatic about the choice of chemotherapy regimen here. They're all fairly active, particularly when partnered with obinutuzumab. Things which don't influence my choice would be whether the grade was the histologic grade was 1-2 versus 3A. Now I know there are some people who contend that grade 3A should be treated with an anthracycline-containing chemography regimen, but again, the older data from Vancouver suggests that there was no clear benefit in 3A for CHOP versus CVP. And people were happy to treat grade 3A with rituximab monotherapy on other studies, and indeed with non-chemotherapy-based induction regimens on the relevant study. So I don't think you can be dogmatic about that. The Flippy score at baseline, I mean, again, that we know it's prognostic, but it shouldn't be used as a way to select chemotherapy regimen. I think the concern about second primary malignancies in bendamustine-treated patients is, again, if you look at the long-term follow-up of the Gallium study, it actually, I don't think it's as big a deal as what it was made out on earlier studies. So really, I think you should be choosing it based on the age, comorbidities, and the fitness of the patient in front of you. In terms of I think I've discussed this already, in terms of the choice of monoclonal antibody, in 2019, when in an era where obinutuzumab is licensed and reimbursed, I can't really think of many reasons not to use it. People have cited a slightly lower incidence of grade 3 toxicity, the lack of overall survival advantage, and the ability to use obinutuzumab in case the patient's rituximab refractory. But it seems like a bit of a backward argument to me. And in pretty much every other instance, we use the most potent regimen that we have. In the first instance, you don't save your more active therapies in case of relapse. And as well as the reduction in POD24 events, there's an improvement in the MRD negative rates. So what about the decision to give maintenance therapy or not? So this area has been thrown into a bit more uncertainty because in the Gallium study, maintenance was mandatory on both arms. If you recall, the PRIMA study, which was published in about 2011, actually looked at the role of maintenance rituximab after an R-chemo induction. And even with about 10 years or 11 years of follow-up at the last reporting, there was no difference in overall survival for patients who received rituximab maintenance after an R-chemo induction. But there was a sustained progression-free survival advantage of around about 2 years, which is exactly how much the rituximab maintenance lasted for. So prior to the gallium, I think people were fairly mixed about whether to use maintenance or not, and it really became dependent on patient preference as much as anything else. When you're using obinutuzumab as the maintenance antibody, I think the issue is that there isn't much in the way of data supporting the use of obinutuzumab induction followed by no maintenance, because the study wasn't designed that way. So it was quite clever design by Roche to increase their sales. I tend to follow the evidence, and the evidence in this case is obinutuzumab in induction followed by maintenance. But because there's never been a trial showing an overall survival advantage from maintenance, I think that if one of your patients starts to experience substantial toxicity and infections or the like during the maintenance phase, and particularly if they receive bendamustine as their induction chemotherapy regimen, we know they're going to be T-cell lymphopenic and increased risk of opportunistic infections, I would have a pretty low threshold for bailing out there. So it's a little bit going to be how it all plays out in the real world. I think that probably most people are tending to do a similar thing. And there is that slight trend for a reduced risk of transformation, and I'll show you this data in a moment. So this is from the Aristotle study. This was basically a meta-analysis of about 7,000 patients treated across about 15 years, a succession of clinical trials, with and without rituximab in induction, with and without rituximab in maintenance. There were no obinutuzumab treated patients in this study. And they aggregated all the data, and they looked at what the risk of transformation was according to how much rituximab you've got, essentially. No single study has demonstrated a substantial difference in transformation rate from the use of rituximab, but when you aggregate all this data together, it's clear that if you don't get rituximab at all, in the green line, that you have the highest risk of transformation, about 8.7% at 10 years. If you had rituximab in induction but not in maintenance, that lowers to about 6% in the solid blue line. And if you had R-chemo followed by R-maintenance, then you had the lowest risk of transformation of all of them at 3.3%. So I think a couple of important take-home messages from this study. Number one, the risk of transformation in the R-chemo era is substantially lower than what we used to think 20 years ago. So we used to think, oh, it's 1% per year. I think if you've got a group of patients who get R-chemo plus R-maintenance, you can see it's substantially less than that at 3.3%. And accordingly, the use of rituximab maintenance, although the PRIMA study did not show a significant reduction, even though it was a large study, when you aggregate it and look at 7,000 patients, you can see that there does appear to be a substantial benefit. So again, it's not any single really compelling piece of evidence, but you can use aggregated data like this to make your argument in favour of the benefit of maintenance therapy. Just a little plug here for a study which we've just opened at Charles Gairdner, and I believe Peter Mack is now open as well. So this is my leverage study. It's a non-chemotherapy design. It's a combination of obinutuzumab with lenalidomide and venetoclax, and we've got our first 2 patients on. They're both doing really well. Patients receive obinutuzumab according to the standard schedule with venetoclax for the first 6 months and lenalidomide starting from cycle 2. They have another PET scan, and depending on the results, will go on to either a further 6 months of all 3 drugs or just obinutuzumab maintenance alone. The primary endpoint is safety for phase 1B and PET CR rate for phase 2. And we will be opening this up to sites across Australia probably around about this time next year when we get to phase 2. So hopefully there'll be, I'm trying to have a site in every state. So that's one to watch out for. Right, how about relapsed follicular lymphoma? This is my suggested approach to the management of relapsed follicular lymphoma in 2019. We've got, firstly, you need to biopsy if you suspect someone has relapse disease, because you want to exclude histologic transformation. Following that, we always prioritise clinical trials wherever possible. In the absence of clinical trials, the key determinant of what to do next is whether there's been a POD24 event or not. If there has, then I think if the patients are suitable for autologous transplant, then that's still, in my opinion, standard of care for patients who are fit and 70 or younger. If they are not suitable for transplant, then the treatment will depend on what they've had in frontline. So you use some sort of non-cross resistant second-line regimen, usually platinum-based, and patients who do not respond to that are then eligible for idelalisib, which is on the PBS, as you know. Idelalisib is a PI3 kinase delta inhibitor. It is active in patients with relapsed follicular lymphoma, but there are some toxicities. As you know, it is associated with rates of grade 3 toxicities such as colitis, which can be quite limiting, as well as pneumonitis, some autoimmune toxicities and increased risk of infection. But there's no doubt it's an active agent. There is a newer PI3 kinase inhibitor called umbralisib, which many of you will have seen on clinical trials. It's available at a number of centres around Australia. There is data in a number of indolent lymphoma subtypes. Compared with idelalisib, it seems to be cleaner on PI3K delta and is not associated with these toxicities such as colitis and transaminitis, and we've had some experience with this in a number of studies. So this is their phase 1 study showing pretty promising activity in a range of indolent lymphoma subtypes. 53% in follicular lymphoma. You could argue maybe a little bit less than idelalisib, but it's certainly better tolerated. And it's available in Australia in a number of sites on clinical trials, as I mentioned, and these studies are ongoing. I spoke previously about obinutuzumab in the frontline setting. A study has also been done evaluating obinutuzumab in the relapse setting, and the Gairdner study looked at the use of obinutuzumab in combination with bendamustine in relapsed rituximab refractory, defined as less than a partial response or progression within 6 months of treatment. And the randomisation was to receive either bendamustine alone or bendamustine with obinutuzumab, followed by obinutuzumab maintenance. And there was a significant benefit for obinutuzumab in this setting. Now, the number of these patients is admittedly very small. It's rare that you see rituximab refractory follicular lymphoma in the absence of transformation. So even though these data have been available for a couple of years, and indeed the follow-up data showed an overall survival benefit, I can't even remember the last time I've had to do it, because patients with follicular lymphoma respond so well, even to rituximab-based therapy. So it's there if you need it, but it's a small group of patients. Right, I said I wouldn't talk about CAR T cells. Here are a couple of slides about CAR T cells. So this is from the Hutch, and probably Cameron Turtle presented this yesterday, and with longer follow-up, but his group presented this at ASH last year, and I really just wanted to highlight there that CAR T cells appear to be a very active modality in patients with follicular lymphoma, probably even more so than aggressive lymphoma. And I'm not going to go through all this other than to say, in patients with relapsed follicular lymphoma, median of 4 prior lines of treatment, the response rate to therapy was, the complete response rate, 8 patients only, was 88%, substantially higher than transformed follicular lymphoma, or essentially large B-cell lymphoma. But if you look at the PFS curve, again, short follow-up, but pretty encouraging for a group of heavily pretreated patients. So we need larger studies with longer follow-up before we can see what the real impact of CAR T is going to be in follicular lymphoma. But certainly early signs are it's going to be highly promising for a select subgroup of patients who are in need of more active therapies and possibly curative, who knows. Right, moving on to large B-cell lymphoma. So really, this section should be how I don't use novel agents in large B-cell lymphoma because, as you know, there have been a large number of negative studies in this space. So this is a slide that I borrowed from a Canadian doctor who has basically updates this every time a new negative phase 3 trial comes out. So here are all the negative studies that have for R-CHOP in large B-cell lymphoma, and we can add, based on the most recent Lugano meeting, we can add Robust to this, which was the R-CHOP plus lenalidomide Celgene-sponsored study. Last year we saw negative results for Phoenix, which was R-CHOP plus ibrutinib versus R-CHOP alone. And so even in these molecularly stratified subgroup studies, we are not seeing substantial advances in large cell lymphoma therapeutics. So Goya was no exception. I was talking about obinutuzumab earlier. It was essentially the equivalent study to gallium, except in large B-cell lymphoma. And it was negative for both progression-free and overall survival. So the development has been abandoned in large B-cell lymphoma. And we know that despite the fact that large cell looks like a similar entity under the microscope, if you actually look at the gene expression profiling, it's molecularly quite heterogeneous. And this slide basically summarizes 6 of the more recent, 5 negative and 1 positive study looking at different novel agents combined with R-CHOP in the treatment of patients with follicular lymphoma. So Goya was negative, Phoenix was negative, Robust was negative, the 2 bortezomib studies were negative, and the one exception to this was the ECOG 1412 study, which was presented at Lugano a few months ago, but that was a randomized phase 2 trial. The dosing of lenalidomide was slightly different to the Robust study, which was industry-sponsored, and the inclusion criteria were different as well. It was an all-comers study as opposed to an activated B-cell subtype-only study. So I think a follow-up randomized phase 3 study needs to be done here. In all of these studies, there was if you tried to tease it out, there was a defined subgroup where there may have been a benefit in the experimental arm. So in Goya, there was a subset of patients which were so-called GCB strong, which maybe look a bit more like follicular lymphoma from a biological perspective, who seem to do a lot better with the obinutuzumab, but again, needs to be validated prospectively. In Remodel B, then the double expressor lymphoma seemed to do better. And in the Robust study for patients with an IPI of 3 to 5 had a non-significant trend toward benefit. So if you go back and do a post-hoc analysis, you can always find some subgroup who does a bit better. There's going to be an analysis coming out at ASH from Phoenix, by the way, so watch out for that. But whether or not any of these things are going to be practice-changing is doubtful unless a randomized study in that particular subgroup is done to prove it. Otherwise, it can be considered hypothesis-generating at best. Management of relapsed large B-cell lymphoma. So again, I think many of you will probably be starting to see this drug appear. Now, the Polaric trial was open at some sites in Australia, but more recently, Roche has very generously made this drug available on a compassionate access program, and we've treated quite a number of patients via this method. Polatuzumab vedotin is an antibody-drug conjugate. The target is CD79B. You can think of it as a similar drug to brentuximab vedotin, where the target's CD30. It's just in this case, the target is a B-cell antigen, which is basically universally expressed on large B-cell lymphoma. This randomized phase 2 trial has been presented a number of times at meetings by Laurie Sen, and essentially it looked at patients with transplant-ineligible relapsed large B-cell lymphoma and compared bendamustine rituximab to bendamustine rituximab plus polatuzumab vedotin. And to cut a long story short, both the PET-CR rate and the progression-free survival was substantially better in the polatuzumab treated group of patients. The PET-CR rate was about 40%, and the versus 18%, and the median PFS was I think about 6.7 months, with a median overall survival of about 12, just a touch over 12 months. Remember, this is transplant-ineligible relapsed large B-cell lymphoma, group of patients with a very poor prognosis. There have been a number of criticisms levelled at this study, and I think many of them are valid. The use of bendamustine rituximab as a comparator arm in the large B-cell lymphoma study is suboptimal. I think no one uses bendamustine rituximab to treat relapsed large B-cell lymphoma. It would have been much more meaningful if it had been done with a platinum-based chemotherapy regimen as a comparator. And it was only 80 patients, and so I think my opinion is that this needs to be replicated in a larger study with a more robust comparator arm. But nonetheless, the drug received FDA approval for this indication on the basis of these data, and it's becoming increasingly available. So the Polaric Study, as I alluded to, is basically evaluating the efficacy of polatuzumab vedotin in frontline. Now, like brentuximab, one of the main toxicities is neuropathy, and so the randomization was actually between R-CHOP and polar R-CHP, so the vincristine was removed, and this study recruited very rapidly, large multi-center international trial, and we're all waiting for the outcomes. It was an all-comer IPR 2 to 5 study, and so perhaps this will succeed where everything else has failed. Right. This drug and this particular subset of agents I think is a really interesting group of agents. There are probably 5 or 6 bispecific monoclonal antibodies being evaluated in lymphoma. In fact, probably more than that, but there are 5 or 6 that are in sort of later phase clinical trials. Roche and Genentech have 2 of them. One of them is this one, which I have a lot of experience with, mosunetuzumab. These bispecific antibodies essentially kind of work like, you can kind of think of them as CAR T-cell light. They are an off-the-shelf drug. They have 2 antibody domains. One binds to CD20 on the outside of B cells, and the other binds to CD3, which is on T cells, and they basically have an immune synapse between them. So it induces a direct CD8 mediated immunological effect with the host T cell against the lymphoma cell. So this is how it's a similar principle to blinatumomab in B-cell ALL, except blinatumomab's not very good against B-cell lymphoma, and these drugs seem to be. The main toxicity of these agents seems to be a thing much like CAR T-cell called cytokine release syndrome. In my experience, the CRS is much less severe and more easily manageable than with CAR T-cell therapy. This data will be presented again at ASH, and there's quite a high-profile abstract regarding this drug at ASH, which you can see for yourself. But this was from last ASH, and this waterfall plot shows that there's substantial activity for this agent across a range of lymphoma subtypes. And this was the phase 1 trial, actually. This included all dose levels. At the higher dose levels, at the current dose levels for large B-cell lymphoma are about, we're running at about 60 milligrams now, whereas it started out at 1 milligram. So it remains to be seen what the efficacy is like in larger studies. But you can see that across the different dose levels, there were a number of patients who achieved CR, 19%, with an overall response rate of about 34% in patients with aggressive lymphoma, and it was higher than this in follicular lymphoma, CR rate of 40% and an overall response rate of 70%. So fairly encouraging early signals for mosunetuzumab. There are about 3 or 4 others which they all seem to have similar activity and similar toxicity profiles, but I'm most familiar with this one because we've had it on trial. So here's my suggested approach for the management of patients with relapsed large cell lymphoma in 2019, assuming that you have access both to CAR T and to polatuzumab vedotin. Basically, if you've got the key decision point is transplant eligibility. If you are transplant eligible, then at the moment I still think that then salvage therapy and transplant is standard of care. Of course, that's being challenged by ongoing randomised trials where patients are being randomised to CAR T versus autograft. But until then, that's still standard of care. If you are non-responder to second-line therapy and you have access to CAR T, then I think that's a good time to use it. If you're not eligible for CAR T or you don't have access to it, and then I think there's a good time to use polatuzumab vedotin plus BR if you have access to that. And as I mentioned, Roche are making that available, and we'll see whether that becomes commercially available in the near future. Right, just to quickly touch on primary mediastinal B-cell lymphoma. I promised when I wrote this slide deck I didn't know that MSD was sponsoring this meeting, but just a few points about primary mediastinal. You know, it occurs mostly in young adults, and there is a female preponderance. Often patients have a bulky mediastinal mass, and there is a biological similarity to Hodgkin lymphoma. The outcomes with patients treated with R-CHOP alone have been reasonably good, but most of those studies have used radiation as well. And as you know, many centres use dose-adjusted EPOCH because the efficacy looks similar, and it has the advantage of sparing radiation, which is important in a predominantly young and female group of patients. In terms of novel agents, probably the one which is most interesting is the checkpoint inhibitors. As you know, checkpoint inhibitors are highly active in Hodgkin lymphoma, and they're approved for that indication. Brentuximab vedotin, also active in Hodgkin lymphoma, but interestingly, as a single agent, not very active in primary mediastinal, which I was surprised by because primary mediastinal does express CD30 quite strongly. Interestingly, in the studies where checkpoint inhibitors were used in primary mediastinal B-cell lymphoma as a single agent, they were pretty active, and with an overall response rate of somewhere around 40%. And this is the impressive thing about this is that relapsed primary mediastinal lymphoma is actually much harder to treat than relapsed DLBCL NOS. These patients have a lower response rate to second-line chemotherapy, and they have a much shorter, they very rarely get autograft actually, because they usually progress and have experienced death from their lymphoma before you can actually get them to transplant. So it's actually quite a different beast to relapsed large B-cell lymphoma. The studies which looked at checkpoint inhibitors in this entity were pretty encouraging, and what was really even more interesting to me was this study which combined brentuximab vedotin plus nivolumab, and when these two agents were used together, they appeared to be a lot more active than either as a single agent. So there was clear synergy here with an overall response rate of 73% and a median PFS which has not been reached yet. So for this group of patients, I mean, that curve is better than the CAR T cell curve in the Zuma-1 study. So phase 2 comparisons aside, I think that combination of BV plus checkpoint inhibitor looks highly promising for a very difficult group to treat group of patients. So here's a suggested approach towards treating primary mediastinal B-cell lymphoma in 2019. Essentially, R-chemo induction. I think personally, if you use R-CHOP, then you should use radiation as well. If you use EPOCH, then you don't need it. If you have refractory disease, then if it's just in the mediastinum, you can actually salvage some of those patients with radiation alone. But if not, then second-line therapy and autograft if you can. But if you can't, then I would be going for either a checkpoint inhibitor plus brentuximab vedotin. I recognise that at this point in time, neither of those things are funded. But if in your perfect universe where cost was not an issue, and that was my patient, that's what I would be doing. Or obviously CAR T if that's available to you as well. But bashing on with more chemotherapy in these patients is not going to do them any favours. So look, I'm starting to get towards the end of the allotted time, and I did have a section on mantle cell lymphoma, but I think in the interest of time, I'm going to skip over that, and I'll just get back to my summary points, which are here. It's not working. Sorry.
Not much help. Open it back up again, maybe.
Well, look, I think I'll basically just wrap up by saying there are a number of really quite interesting and highly active novel agents emerging, which are now increasingly becoming available for our patients with lymphoma, both in the frontline and the relapse refractory setting. None of these drugs are chemotherapy agents. They're all either immunotherapies, they're molecularly targeted therapies, they are they're cellular immunotherapies, they're working in a number of ways. They have favourable efficacy to toxicity ratios. I think that clinical trials should be prioritised wherever possible, and certainly, as you heard from Donna, I mean, our philosophy here is that every patient with lymphoma should be offered a clinical trial if it's available to them, whether they're newly diagnosed or whether they're being treated in the relapse refractory setting. I think it's even more important in the relapse refractory setting, and without the participation of our patients in these studies, we'll never advance the field. So I'd like to wrap up there, and I'm very happy to take any questions. Thanks for your attention.
Thanks, Cheah. That's fantastic. Sorry about the technology.
Oh, no, that's
I had
fine.
issues with it before.
Yeah, no, that's fine. No problem.
Is there any questions? It's a very exciting time.
Could you briefly summarise how you treat mantle cell lymphoma?
Sure. I thought I had till 8. Is that right? Or
No, you've got to take to 15.
Oh, do I?
15 minutes.
Oh, sorry. I thought I had to finish at 8. Well, in that case, I can do it. So I thought I had to finish by 8 o'clock.
Oh, sorry.
No, that's all right.
No. Oh, bring
Okay. I feel like that was a request for an encore. Anyway, so here's how I approached mantle cell lymphoma in 2019. So the treatment dichotomy for mantle is basically, are you fit for transplant or not? So if you are, and that's the green box, then at our centre we're currently still using Nordic MCL2, which is maxi-CHOP, alternating with high-dose cytarabine. Now, there have been a whole range of studies using a whole range of different induction regimens. The only one has been randomised, and that showed a benefit. That was the European Mantle Cell Lymphoma study, which showed a PFS advantage for CHOP alternating with DAP. Versus CHOP alone as induction in patients with transplant-eligible mantle cell lymphoma. So I know that there are some people who use that regimen, and I think that's perfectly fine. You know that the French group used an induction which was much simpler, which was 4 cycles of RDAP alone, high-dose cytarabine, platinum salt, and steroids, followed by transplant, and then the randomisation in that study was to rituximab maintenance or not. And those patients have done very well, but the follow-up is not as long as the older studies, which have probably got the best data in young patients with mantle cell lymphoma. You know, median PFS probably about 7 to 8 years, with about 25% of patients still in remission out at 10 years. So I think that you have a choice of CHOP alternating with DAP, DAP alone, or the Nordic Mantle Cell Lymphoma 2 protocol. Some sort of high-dose cytarabine-based induction therapy is the way to go there, and whatever your centre has experienced delivering is fine. In terms of a transplant, then anyone who responds should go on and receive transplant. Again, there's various different regimens used. I know that Peter Mac uses Bumel. We use Beam. I think most other centres do as well. I think that the data there is fairly comparable, and I don't think you can be too dogmatic about it, but high-dose therapy seems to be necessary. And in the most recent follow-up of the one randomised study which addressed the role of autograft, which was done by the European Mantle Cell Lymphoma Network and published in 2005, has now shown an overall survival advantage to the patients who received autograft. So I think that question has been answered. I think you should autograft patients who are transplant eligible. The role of maintenance rituximab after our chemo followed by transplant is contentious, and Stephen Legoul was out here recently, and I think he did a patient day for you, Donna. So the Lima study was a large French study in which patients with transplant-eligible mantle cell lymphoma were randomised to receive RDAP times 4 followed by an autograft, and then were randomised to rituximab maintenance or not. And the patients who received rituximab maintenance for 3 years actually had superior overall survival. And so again, this is a non-PBS listed indication, unfortunately. And in a perfect universe, then I would give rituximab maintenance to my transplant-eligible mantle cell lymphoma patients after autograft, but it's currently not on the PBS, which is an issue. So we've written to the government previously to try to address this, but it doesn't appear as though that's going to be sorted out anytime soon, unfortunately. It's possible that when rituximab biosimilars enter the market, which is imminent, and the cost comes down substantially, that it will become more palatable for either hospitals, health services, patients to fund this themselves, but or perhaps we'll see some indication creep once that gets relaxed, but we can only hope. But certainly that's a little bit of a thorny issue at the moment. In the yellow group, patients who are fit for what conventional dose therapy, and that's what I would consider something like R-CHOP or bendamustine rituximab. There's good data for both. I think if you're going to use R-CHOP, then patients should receive rituximab maintenance. And again, I know that's not strictly speaking reimbursed, but the data clearly showed a benefit for R maintenance after an R-CHOP based induction. If you're not intending to do that, then I think that there are stronger data for the use of bendamustine rituximab than there are for R-CHOP on the basis of the BRIGHT and the STEEL studies. Again, these were not overall survival advantage, it was a PFS advantage, but in mantle cell lymphoma, I think PFS is meaningful. Patients who are unfit for conventional dose therapy in the orange box are best treated with lower intensity regimens. You can try reducing the dose of bendamustine, or you can treat patients with CVP. CVP is really palliative in mantle cell lymphoma. It's not a particularly active regimen, and I'm not, without wanting to labour the point. I mean, I think if you've got a patient who's not suitable for chemotherapy with mantle cell lymphoma, then you should be A, trying to put them onto a clinical trial, but B, if you can't get them onto a trial, then I would be reassessing their disease very, very early after some sort of regimen like CVP. And if there's any suggestion of lack of response, that you're going to ibrutinib as the next line of therapy. There are a number of trials which are looking to advance standard of care in mantle cell lymphoma. This is one that we've been heavily involved in. There was a similar study called SHINE, which used ibrutinib and with bendamustine rituximab as a background, with the randomization for the addition of the BTK inhibitor or not. So 2 studies with essentially identical design with the primary endpoint of progression-free survival. I would be very surprised if either of these studies were not positive for their primary endpoint, but we've been waiting for the SHINE data for a while now, and it's an event-driven analysis point, so I don't think it's going to be presented at ASH, which means that it's going to be another 6 or 12 months away. I suspect that the addition of ibrutinib in frontline is going to substantially change things. This study summarises the efficacy of ibrutinib. It was a randomised study in patients with relapsed mantle cell lymphoma. It's relatively old data now, but it established a clear role for the use of ibrutinib in patients with relapsed mantle cell lymphoma. The comparator arm, again, was suboptimal. I mean, temsirolimus is registered in the EMA, and it's an okay drug in relapsed mantle cell lymphoma. The response rate's about 20%. Ibrutinib clearly much more active, and there was a substantial benefit in progression-free survival. So there's no doubt you've got a patient with relapsed mantle cell lymphoma. Ibrutinib's on the PBS and it should be used unless you have a clinical trial, because a lot of the newer BTK inhibitors have got cleaner inhibition of BTK, and that seems to translate to a more favourable toxicity profile. So I mean, we've had around about 6 or 7 BTK inhibitors on trials now, and all of the ones subsequent to ibrutinib do seem to have a favourable tolerability profile. So there are both on-target and off-target toxicities associated with BTK inhibitors. So it seems like the bleeding is an off-target thing, because that's mediated through an effect on platelets and ITK rather than BTK. It seems like the increased risk of infection. So you know that some of the studies where patients were treated with ibrutinib, particularly with primary CNS lymphoma, where they had high-dose steroids as well, there was an issue with invasive fungal disease, and I've certainly seen that. That seems to be an on-target BTK thing, because you need BTK to for your innate immune system to for the neutrophils to actually phagocytose fungus. So if you block BTK, patients do seem to be at an increased risk of invasive fungal disease, and that's an on-target effect. Similarly, the hypertension seems to be an on-target effect as well, and you know that there's a substantial rate of grade 3 plus hypertension. I feel like it's said to be 20%, but in my experience, it feels like about 60% of patients treated with BTK inhibitors for 2-3 years. I mean, it's kind of a good problem to have, because these patients weren't living for 2 to 3 years before, but now that when you see them 2, 3, 4 years on, they, in my experience, almost universally seem to have hypertension, and it can be quite a difficult hypertension to treat. I've got one lady who's on like 6 different antihypertensive drugs to try and keep her blood pressure under 150. And the other thing to say is that if you don't have access to clinical trials and you've got a patient with relapsed mantle, then you should use ibrutinib sooner rather than later. If you wait to later lines of therapy when the disease has acquired more resistance mutations, the efficacy is not as great. And this is data presented by Simon Rule showing that if you use ibrutinib at first relapse, in the curve on the top here, I can't really make my pointer work, but on the left PFS curve on the left, the curve that runs across the top is the 1 prior line of therapy group. And so everyone thinks back to that original phase 2 trial where the median progression-free survival was like 18 months or something like that, and think, oh, well, you only get a year and a half out of it anyway. Well, actually, if you use it at first relapse, it actually seems to be substantially better than that. As you'd expect, and your median PFS probably exceeds 2 years in that setting. If you use it in a patient who's had 5 prior lines of therapy, you're not going to get as much mileage out of it. So here's my approach to relapse mantle cell lymphoma in 2019. Of course, clinical trial is the first preference always. If no trial available, then I think ibrutinib should be the first drug that you reach for. Patients who don't respond to ibrutinib, again, should be preferenced for trials. If not, then basically you'll be using some sort of palliative non-cross-resistant therapy. For patients who achieve a good response to ibrutinib, then there will be a decision point to make, and based on their biological characteristics, such as, do they have TP53, things like that, you might make an estimate of how long you expect the ibrutinib to last for. If they've got very high risk biology, high Ki67, they're TP53 deleted or mutated, you might, and they're suitable for allograft, then that's the time to do it, in my opinion, because you're not going to expect the ibrutinib to cure them, and if they've got a high risk biology, they probably aren't going to get much more than 12 months out of the ibrutinib, so you should probably act on it and make that a decision point then. Probably the most active, and this is just to show you that patients with blastoid or pleomorphic histology actually don't do that well with ibrutinib. They have a median progression-free survival of 5 months compared to 15 months with non-blastoid histology. These patients are obviously heavily enriched for the other high-risk biological features like TP53 aberration and high Ki67. So this study's just finished recruitment and we're waiting for the readout. The Sympatico study looked at patients with relapsed mantle cell, and again, this study was based on the phase 2 AIM study run by Contam at Peter Mac, in which they demonstrated high response rates for the combination of ibrutinib plus venetoclax in patients with relapsed mantle cell lymphoma. So this phase 3 trial is basically looking at whether the addition of venetoclax to ibrutinib for patients with relapsed mantle that's BTK naive improves things. So we should have a readout from this in the next couple of years. And finally, the approach to patients with mantle cell lymphoma who are BTK resistant. In my opinion, this is one of the big unanswered and important questions in mantle cell lymphoma at the moment. I've selected 4 of the trials that we have available at our centre for patients with mantle cell lymphoma who've relapsed or progressed after BTK inhibitor-based therapy, and there are many more. But I'm lying. I don't have the CAR T cell study, but I've got all the other 3. So the four options are: there's a class of covalent BTK inhibitors which seem to be active in CLL and mantle cell lymphoma bearing the C481S mutation, which, as you know, conveys ibrutinib resistance in about 40 to 50% of patients with CLL. So this class of covalent BTK inhibitors, and there are 3 in development that I know of, and we have 1, certainly seems to be active in patients with B-cell malignancies that have relapsed or progressed following BTK inhibitor-based therapy. So we need more data on these drugs, but the appeal obviously is there because they're simple once-a-day drugs. We know that BTK is a validated target in mantle cell lymphoma, and so if you've got a drug which somehow circumvents the resistance mechanism for ibrutinib resistance, then that's obviously highly appealing. I mentioned umbralisib earlier. Umbralisib and other PR3 kinase inhibitors are being explored in mantle cell lymphoma that's progressed following BTK. The original study of idelalisib in mantle cell lymphoma actually showed a reasonable response rate. It was about 40%, but the problem was that the PFS was very short, so patients developed resistance very quickly. Whether that problem has been fixed with the newer PR3K delta inhibitors remains to be seen. CAR T cells, from the early data that we have seen, I think Michael Wong presented at ASCO in the middle of the year, we need a larger number of patients and longer follow-up, but it appears that CAR T does not appear to be quite as active in mantle as it is in large cell or follicular, so it may be that CAR T cell is not the answer for these patients. And finally, the bispecifics, which I showed you some slides on earlier, are being explored in mantle cell lymphoma as well. I haven't seen mature data on the efficacy in this subgroup of patients, so we'll have to wait and look for that. But clearly, this ibrutinib resistance space is where we've got a lot of work to do. Right. Oh, there you go. There's my conclusion slide. Great.
Thank you. Right on time.
No problem.
Thank you, Cheah.